Welcome to this morning's webinar, which is entitled Implementation of Telehealth During the COVID-19 Pandemic and Beyond. My name is Nicole Rankin. I'm a Senior Research Fellow in the Faculty of Medicine and Health at the University of Sydney, and I'm the moderator for today. So this webinar is brought to you by the Cancer Implementation Science Community of Practice. The community is led by Dr. Ben Smith from the Centre for Oncology Education and Research Training Translation, or CONCERT, and the community provides a forum for members to collaborate on the translation of best evidence into care and to develop a rigorous research program on how to improve the uptake of evidence into practice. The community includes representatives from across the Translational Cancer Research Centres, or TCRCs, of New South Wales. And these centres are funded by the Cancer Institute New South Wales, as is the community of practice. So this webinar is a collaboration between CONCERT and the Sydney West TCRC. So before we begin today, I would like to show my respects and acknowledge the Bedegal people of the lands on which we meet from the University of New South Wales, who are the traditional custodians of the land, and also acknowledge the people from your lands on which you are residing today, and to acknowledge and show our respects to our elders, past, present, and those emerging. So I think this should the beginning, so apologies that this hasn't been up. There's the title page. Okay, so our program for today, I'm going to start with some introductions to our speakers. Each of our speakers is going to present one after the other for between 5 and 10 minutes, and then we'll have a question and answer session towards the end. So our first speaker this morning is Professor Sabe Sebastian, who is the Director of the Department of Medical Oncology at Townsville Cancer Centre. And Sabe is also the Clinical Dean of the College of Medicine and Dentistry at James Cook University. He has designed, implemented and published on various technology models to enhance rural access to cancer care services closer to home. And so in collaboration with COSA, Sabe has led the development of the tele-oncology guidelines and the Australasian telehealth model. As the chair of the Queensland Health Statewide Teletrial Working Group and co-chair of the Australian Teletrial Consortium of COSA, Sabe has been leading the implementation of the teletrial model in Queensland and indeed across Australia. So I'll hand over to Sabe and we'll hear his presentation now. Thank you very much, Sabe.
Thank you. And so today I thought I'll cover quickly the telehealth before, now and after COVID. And also then just touch on how we can use implementation science to sustain telehealth implementation. So you could see here in this slide, telehealth is traditionally used for rural care, and we have many models for consultation, supervision, and treatment. And recently we have teletrial models to enhance rural and regional access to clinical trials closer to home using telehealth. So in terms of evidence, a lot of the telehealth models are now supported by literature for feasibility, acceptability, safety, cost effectiveness, and most importantly, expanding rural scope of practice. So in terms of the teletrial itself, we completed a pilot through COSA, and what that showed was that you could create interconnected clinical trial networks and systems so that the patient from rural regional areas can have access to clinical trials closer to home. So now many things have changed during COVID for telehealth. So because of the MBS items, there is use of telehealth within metro areas and also in general practice setting. This has created some opportunities and challenges. So the clinicians now may have to rely on family members as support persons for the patients, and also it allows many family members to dial in to a patient's consultation. And end-of-life discussions, breaking bad news, which are usually undertaken face-to-face, now may need to happen on telehealth. And also the other thing I've been observing is that a lot of people are doing telehealth who may not have met the patient before, and also who may have not been familiar with the telehealth models. But this is an exciting opportunity COVID has created for us, among all the chaos it created, that now there were a few patients from Hobart were able to remain on a phase 1 trial from Alfred in Melbourne, using the teletrial model, breaking down the state borders between Victoria and Tasmania. And most importantly, this is where the system agility comes in. This teletrial cluster was actually set up and activated within 4 weeks. It's not all rosy. There are many ongoing issues, technology and network issues, lack of coordination, and also there is access to vulnerable groups. But nevertheless, we are seeing many benefits created by the telehealth and the MBS items. You could see that telehealth now is connecting patients, specialists, primary care, families, allied health and supportive care professionals. And what it does, it really enforces person-centered care, less disruption to work and family routine, even for metropolitan patients. Because of the specialist primary care interfaces, you have better shared care model of service delivery that need to be taken into the future. There's multidisciplinary care. And also the COVID has exposed health system redundancies while highlighting system agility. But also I just wanted to highlight that as a practitioner, the hospitals actually now much better places or pleasant places without overcrowding for doctors, nurses, and patients. So how do we maintain some of the benefit? This is really at policy level, easier said than done. So development of a holistic and value-based telehealth system for all Australians, regardless of geography and provider setting. And there are many organizations now lobbying for maintenance of MBS item for carefully selected indications. And then incorporation of policy into operations into routine practice. So how do we use implementation science to achieve all this? I think the implementation science, it serves two purposes. One, for a clinical or researcher, middle management or hospital services purposes. It just gives you a checklist where if you meet all of them, you are going to ensure successful implementation. But also I've been using in the last few years, when I debate with my managers or the middle managers about the need for some resources, the implementation science framework actually articulates some of the requirements. So it makes our argument much stronger. So there are many frameworks. Paris framework is one of them, but planning needs to include education and management of change, consideration for people with access and literacy issues, and then evaluation of impact and criteria for evaluation need to be decided upfront. And I just wanted to refer you to this article in terms of training and education, especially the frameworks for doctor-patient communication on telehealth. And this is in the recent MGA Insight. So I'll just take you through the Paris framework and see how that can be useful for telehealth sustainability. So we start with the evidence. So I've shown that evidence is there. So we tick that box. Contextual readiness. So leadership support, environment, the organization. You know, that's always a struggle, but you can work on that. But one of the things I've been realizing in the last 5-10 years is actually the facilitation component. Whether it is at a system level or at the elbow level, if you don't have facilitation, it's very hard to sustain any program. So for me, as a clinician or researcher, project support, if you don't have that, it's very hard to rely on goodwill all the time. So if Paris framework is too academic and technical and difficult to use, then the strategic implementation framework proposed by Mitchell and Chambers, it actually gives you a practical separation. So it divides the implementation into 3 stages: setting the stage, active implementation, monitor, support, and sustain. You could look at this and the components, but my observation is that setting the stage is probably the most difficult stage. And if you front load a lot of energy in that stage, then the rest of the program should flow reasonably easily. So in this slide, I'm trying to break down the setting the stage so that we take a systematic approach to planning. So we start with the problem, and then you talk about solutions and talk about implementation plans and enablers and barriers. But I feel that each flow, you move on only when you have ticked yes to each of them. And I just want to highlight that the problem probably have to be the number one, or instead of calling problem, I'd say purpose of the project. So it's very important for getting strategic alignment of purpose among the stakeholders so that you don't need to waste time arguing about the details later on. So one other thing I've been using for this is the golden circle, the why, how, and what. This is really, I found it's a useful model to get strategic alignment of purpose among the stakeholders so that you can explain this first, why, and then take the stakeholders along your journey. So this is how you drive action through purpose. So then the last point I wanted to point out is actually the clinician levers. All these frameworks assume that once you tick the box and resource them, suddenly the implementation plan and the program just lands on the tarmac and just everything is hunky-dory. But it's actually quite a difficult thing. So if it is a government, you can push through anything you want, even if it is a wrong thing to do. And if you're a CEO, probably you can push through things. But if you're a clinician, researcher, or a middle manager, what power do you have to push through things? So this is where I think the clinician levers come in. And items or mechanisms clinicians can use when they face barriers to implementation, provided they know they are doing the right thing by checking all the implementation frameworks. So some of the examples are really when there is, you might even find that when there are significant problems, your stakeholders or colleagues may even refuse to accept that there's a problem. So to move these people on the stakeholders along the journey, then you can apply things like reference to accreditation standards, safety standards, and then linking to consumer advocacy bodies, linking to clinical peak bodies, linking to unions and political alliances. And then, the media and all those things are levers that actually the clinicians have, but they may not realize they may have. But the important thing is you've got to use those levers judiciously so that you don't waste the big levers up front. So I hope that I have summarized the current status, and the COVID has precipitated the need for telehealth as a social distancing measure. And certainly the uptake was increased. There are many flow-on benefits. There are many lessons we can learn to redesign the system for the future. System level interventions at policy and clinical levels are important. And I think the implementation science can inform sustainability mechanisms and QI approaches for the future. So thank you again, and warm greetings from Townsville.
Thanks, Save. That was terrific in terms of giving people an overview of what work you've been doing, but also how implementation science can contribute to the thinking that we have around how telehealth can be used and how we can build the infrastructure around it, not just in terms of the technology, but in terms of the people, resources, and getting our stakeholders involved in important initiatives. So we've got time for about 2 questions. I just wanted to point out to people that if you want to ask a question of any of our speakers today, please use the Q&A button down the bottom in the centre of the screen and post your questions so that we can read those aloud. So, Sade, just to begin with, we've got a question about, is there any training available for clinicians on how to use telehealth?
Yeah, there are actually so many training modules. I think all the colleges have training on telehealth. I think the Center for Online Health, UQ has on their website, there are telehealth training. Yeah, so I think if you search, there are a lot of YouTubes on training it. So it is plenty out there. But I think the main thing is if you know how to use FaceTime, and then you add some safety and quality governance, and make sure you have a telehealth coordinator or an admin support, I think then things will flow.
Terrific, thank you. I'm just wondering too, we've got a question here about whether there's any indication that the MBS items will be maintained after the COVID pandemic has finished.
Yeah, I think that is always difficult political question to answer. But at the moment, because of the benefits, there are many organizations actually lobbying for maintaining some of the items. But I think so it will come down to the lobbying. But I have a feeling that there will be maintenance of at least selected ones, because there's already a lot of, even state departments are talking about how do we take advantage of the current lessons we learned. So I'll be surprised if they stop it suddenly.
Terrific. We might hold over on any further questions at this point and go to our second speaker now. We will take further questions for all panel members towards the end of the webinar. But at this point, I'd like to introduce our second speaker, who is Michael Marthick. So Michael's the founder and managing director of Care Connected, which is a virtual health clinic focused on providing allied health and nursing services to people with cancer. Michael's background is in exercise physiology, and his clinical and research interests include the optimal delivery of support for patients through digital health interventions. Michael's currently completing his PhD at the University of Sydney on digital health applications for remote teleoncology rehabilitation. So over to you, Michael.
All right, so just a bit of an introduction really. As Nicole said, I come from an exercise physiology background and really kind of interested in remote care and supportive care, and with a big interest in cancer. So Care Connected really was set up around 2017 as a digital health clinic only, focused on those type of services. We really focus on allied health and nursing services. And for us, our model of care includes connecting from anywhere using a WebRTC based platform. We have a whole range of different nursing and allied health practitioners as part of our team. We've got around 35 in our core team at the moment. We have a focus on nursing care coordination as a central theme in our service delivery, and really an individualization of these remote support programs. We're getting more and more focused on things like automated onboarding, remote prom and prem collection, and other remote monitoring kind of capabilities that we can bring forward to really enhance care, enhance user experience along with that. Just as a kind of key point, we use the Attend Anywhere platform as a platform for our web calls, or our video calls rather. The nice thing about that from an implementation perspective is that our video call button and our entry point is just on our website. So patients get directed to our website rather than having to download anything or go to a specific link. They just get directed to our website and click on Start Video Call, and they get brought onto a virtual waiting room environment. We find this, particularly with people with poor tech literacy, we can guide them through this process a little bit easier than a calendar invite or other kind of invite that they might get as part of a video call or telehealth service. So really prior to COVID, just a bit of background on us and how we approached kind of telehealth. We were really telehealth focused. 98% really of our consultations are done remotely. We were focused on B2B. So prior to COVID, as everyone would know, particularly in allied health service space, there's a real lack of funding from private health insurers, but also through the MBS. So we had to kind of approach this in a different model and go to funders like insurers, because we could then offer services at no cost to patients. So we know that financial distress and financial concerns are large in the cancer population. So we wanted to do what we can from that perspective. Also importantly, we gained accreditations, or ACHS accredited, and I think one of the first telehealth focused clinics to do so in terms of their programs. And therefore we can show payers and other funders and other collaborators that we have a good governance model and risk management model associated with that. We had great feedback, again, prior to COVID, to using a model. We offered lots of appointments after hours, say, or on weekends. And this flexibility of care was well accepted by patients and their carers and funders. We do have a telehealth hub as well. So from an implementation perspective, we were trying some different alternatives up in Icon and Mackay. They've got a telehealth room, so we can now use that and offer our team remotely. So essentially it's a turnkey workforce for a cancer centre that might not have allied health capacity on site. They can now bring it in using these hub type of model. Really the impact has been on our service that through the Medicare benefits that were described previously, we can really expand our services to more of a direct-to-consumer model. So rather than having to go through a different payer, now we can start going through and having patients self-fund and offer a bulk billing service for that as well. So that's really opened up that channel, which wasn't really available to us. This kind of really kind of links in with wider adoption. We've seen kind of more than 10 million really telehealth consults billed as of mid-May. This has really grown adoption of healthcare professionals with telehealth, consumers, just in their knowledge and awareness of remote care and digital health options like telehealth. And that's been a really exciting change with a really kind of stressful last couple of months. Within our own patient population, we've seen a huge increase in support requests, particularly early. So in March and April, we saw a large number of inbound calls coming out. So we had to adjust for that. Patients and carers wanting to know more details, be educated on COVID and other surrounding issues with that from our nursing team. And really for our own workforce as well, even though we do operate completely remotely, we have to look after our workforce. There's more kids at home and partners at home. And it's been quite stressful for everyone. So looking after our employee mental health particularly has been a big focus for us. Big adaptations needed. So again, just practically for us, making things work. From a billing perspective, primarily, we've had to change the model of payment processes, how that works. So we've gone through that with a SaaS provider, so a payment gateway essentially, and consumers and our team to really operationalize that and make that work. So again, we have a virtual terminal that we can collect details securely, that can send a link to a patient via an SMS where they can put in their details. So we don't have any visibility of their credit card details. Payments are accepted, Medicare benefits paid if needed. Really, we're growing our awareness and again, as I mentioned, our workforce. So being more adaptable, offering more flexibility than we did with our hours for staff and providers. more check-ins, checking in on staff wellness, more kind of wellness activities that we're putting together for staff as well. So that's been really a great initiative with our team. Some practical tips. So if people are setting up a telehealth kind of allied health service, some of our team are bilingual, which is really helpful. But we're also piloting a translation service. So can we have a third-party translator come in and enter the room, or join on the phone and be audible while the consultation's happening? Tech literacy is always a concern and always raised. So we spend a lot of time on making onboarding as simple as we can. We spend time setting up participants. We have one of the nurse coordinators navigate people who have a lower tech literacy through that as much as possible. And then we can just offer phone consults if needed. So we try and be as flexible as possible. I think for any service to be implemented, multiple models of delivery need to be explored. We're flexible in our care as well. So we send out tablets with 4G cards if we can, even hard copy exercise programs for people that don't have internet access at home, that might want an exercise program from a physiotherapist or an exercise physiologist. We also use prompting a lot. So we have automated SMS and email reminders going out to patients prior to their consultation time. And really, as was mentioned, we have fingers crossed that a proportion at least of these telehealth items will continue post-September, with focus on allied health. Allied health, in my mind, is often forgotten, or is last to, receive some funding. So hopefully a lot of this funding can be continued post-September. It's quite restrictive anyway. For instance, the chronic disease management items are limited to 5 per calendar year, as they are face-to-face. So we're hoping that there's more flexibility that's brought in there. We're really going to see an awareness growth over the next couple of years because of this as a catalyst. This has been the biggest change, as we've all seen over the last few months, in digital health adoption. So with healthcare professionals, with patients, with a whole range of people, the awareness is going to continue post-September, and that's going to have long-term impacts on healthcare. I think patients are going to start demanding more and more remote care if possible, and if it works clinically for them. And then we'll see an increase in remote monitoring. So expansion of, a telehealth 2.0, if we want to call it that, using remote monitoring devices at home, and either a rehab in the home or hospital in the home type model is going to continue to expand. Thanks, everyone.
Terrific. Thank you so much for that, Michael. We've already got some questions coming in, so we'll ask a couple now and then hold the rest over. Michael, the first question was about, similar to access for patients from non-English speaking backgrounds that you've talked about there with potential for translation services. Is the Care Connected program looking at how to better support vulnerable populations, particularly people in remote areas, people who are financially challenged, or our Aboriginal and Torres Strait Islander communities?
Yeah, absolutely. I think it's for us to get a proof of concept up. Unfortunately, we've gone through pathways like life insurance or private health insurance, but we know there's a huge number of patients that don't have access to those funding models. So therefore, Medicare has really changed the game with that now we can access, bulk billing allied health services remotely to people who qualify for, say, a GP management plan or a mental health care plan. So I think that's a starting point to allow access to people, who are more vulnerable, who might not have access in the past. But also creating community links. As I said, we think the hub idea is a nice idea, that the patient, can go to a hub or a community centre, say, or a pharmacy or some other type of safe place. They can access these type of services remotely.
Terrific. And Michael, just one other question. In terms of your communication with patients when they first get started with your program, how do you manage issues around consent and any concerns about data safety or privacy?
Yeah, absolutely. So we have, we try and be as clear as possible with our consent process. So we use a care coordination platform that allows us to capture patient forms, so their patient reported outcomes, their demographic data, for instance, and also their consent. We also follow this up with, with a nursing assessment that, patients are really aware of how we use their data, what we use it for, what information, say, goes back to their funder, if any. So we try and be as clear as possible. And then spending time with patients who, might not have the literacy to kind of understand that, and spending that time with the nurse to go through that is of real value to us, and well worth that time to make sure that people are actually informed in terms of what information they're giving, how we're going to use that information, and moving forward, what are the plans and how we're going to use it in a clinical setting to improve their care, not just collecting data for the sake of collecting data.
Terrific. Yeah, really important points. Thank you. Okay, we might hold the questions there and come back to more in our panel. Don't forget, if you want to put any questions for either Sabe or Michael at this point, to use the Q&A button at the bottom of your screen. Our final speaker today is an inspiring woman who I had the pleasure of talking to earlier this week. Her name's Marie Balmain, and Marie lives in and manages Avon Downs, which is a remote cattle station that spans across the Northern Territory in Queensland, covering 2 million acres, which is a bit mind-boggling, I think. Marie was diagnosed with breast cancer almost a year ago, and she's had various rounds of treatment, having her first session of chemo 2 weeks after she'd had her second baby in Townsville. And Townsville is more than 1,100 kilometres away from her home, so she was so glad when her oncologist advised her that she could continue treatment via telehealth and travelling to Mount Isa Hospital for her chemotherapy, which is about 270 kilometres away. So Marie, welcome. And for those people who are seeing you on their screen as Sabina Knight, that's just your login name, but definitely Marie Balmain. So I'll hand over to you to share your slides. Thank you, Marie.
Thank you, Nicole. And thank you very much to be given a seat at this table and a voice, particularly to the oncology team in Townsville, Professor Sabe. I'm a very grateful recipient of your knowledge and what we know is telehealth. So I guess I'm an end user, for the want of a better word. I am the person that gets to enjoy all of this great technology that you've all been talking about. Everyone can see my screen, okay? Yep. So yeah, I'll just begin at the start. For me, as Nicole touched on, nearly 12 months ago on the 12th of June, I was in Townsville to have our second baby, little baby boy, Harry. He was born on the 12th of June, and that same day, 6 hours later, I was handed a cancer diagnosis. At least stage 3 is what we knew by that day. And that, we were to begin a fairly big round of treatment. It's probably not the picture you really want to put on your wall, but that's a little snapshot of what we found was going on in my body, a week after having our baby. To say the least, it was extremely stressful. You're dealing with a diagnosis that's really serious. This one was HER2 positive, hormone negative, stage 3 locally advanced. So it's only represented about 5% of breast cancers worldwide. I was in a spot of bother. It wasn't good as we started to learn, the treatment I was going to have to undergo to get on top of this. So, as Nicole mentioned, we live quite remotely. We live at Avon Downs at 2 million acres, as she described. It's 8,700 square kilometres for people that do that. It's the size of Puerto Rico. It's a beautiful big remote haven where we run 20,000 head, have 16 staff. We've got a lot going on. It's a beautiful place to raise a family. So the idea of leaving that or behind to sort of go down that road of 16 rounds of neoadjuvant chemotherapy, double mastectomy, and then 25 rounds of VMAT radiation. It was extremely daunting. We first thought that we would have to move, that we'd never heard of telehealth. We've enjoyed, as a family and a collective family, really, really good health. So we didn't know that telehealth existed until I had that first initial consult with Dr. Joshi from the Icon Cancer Clinic in Townsville. So to learn that, we potentially could stay where we were was extremely, extremely stress relieving, I guess, in those first days. So that's just a bit of a snapshot of Avon, and what we've got going on there. So we've got a fair bit going on. So, it was great to know that we could actually potentially be there. So, and it was just as far as a conversation, Dr. Joshi just said, well, once he learnt where he knew where we lived, he ran the Wednesday consults in at Mount Isa. I switched from private across to public, and we just got started with my second round of treatment out at Mount Isa. So for us, it was very seamless, and obviously this is all pre-COVID as well. So telehealth is a way of life, as Professor Sabe touched on. It's got a pretty far and wide-reaching network, particularly in the north of Queensland, and obviously I'm a little bit further west than there. So this is a way of life for us up here. As bush people, we embrace technology and don't really have a problem with embracing technology. If that saves us a few Ks, then that's all a good thing. As you can see, we're a fair way from Macca's. Not that that's something we really eat, but we do produce a few cows that end up there. So, it's good to know that if we can cut down Ks, then that's a really big thing for us. So, I mean, for us, pre-COVID, telehealth was just a way of life. We embraced it straight away. I've seen there's a few questions around patient security. Look, we never had a problem with that. If it meant we could stay at home, then that was great news to us. They could have put my details in Times Square on the big billboard. As long as it meant that I was going to get the treatment, I wouldn't have had a problem with it. So security's never been an issue for us as far as wanting to receive it. We just wanted to live where we wanted to live. So for me, telehealth has enabled us to do that. There has been a few challenges along the way. Some of them are around distance. I've had a few close calls with some cattle getting in and out of treatment. That's just part of life and driving on the roads. But I mean, it's a small thing compared with actually being able to stay in your home. The Aboriginal people actually have a really, really good word for it. It's called off country. So when I've done it the toughest, and mentally and emotionally and physically, it's when we've been off country. Been away for the 25 rounds of VMAT radiation, surgery. I had over 2 week stint in hospital just with different complications with chemotherapy. That's when we did it toughest as a family, and the social structure and the feeling of wellness was definitely never there whilst we were off country. So telehealth's enabled us to be on country, and I think, I'm no doctor, but I'm sure the people that do well mentally are the ones that do well physically as well. I saw a few questions about whether getting bad news might be an issue via telehealth. I've had my fair share of bad news via telehealth. It just rolls on for us. I've seen no difference in having Dr. Joshi physically in the room with me or on the screen. I've just got a photo there of the telehealth setup in Mount Isa. That's Dr. Ryan Beasley on the right. He's also a pharmacist. He sits in on all of my my sessions, and that's one of the fabulous cancer care nurses in Marianne Williams. So I have the same team every time. I have a very, very qualified doctor / pharmacist sitting with me. You know, we have quite lively sessions, Dr. Joshi and I. We've had some very robust discussions around my treatment. I'm a massive consumer of oncology journals these days and clinical trials. I read up on far too much. I probably should be focusing on reading Dr. Seuss to my children, but I do enjoy the odd medical oncology journal nowadays. So I go to those meetings fully armed, particularly in the early days when everything was so unsure. You know, I had that diagnosis and we weren't sure how it was going to go. So, you know, it'd normally go like I'd roll in and get settled, and then Dr. Joshi and I'd have a couple of rounds in the ring with what we thought was going to happen. And, you know, I've got an amazing amount of respect for him. You know, I'm probably a big picture person, so I get involved more than the average person. You know, we're kind of required to with our business as well. So I treated my health journey as the same way. So we really got stuck in and worked out a plan and had some plan Bs and Cs just in case I didn't get PCR, which is pathological complete response after surgery. So, I mean, yeah, the telehealth for me has been incredibly positive. You know, I can't really fault it as far as how it's been set up and delivered to me in Mount Isa. And like I said, having oncologists face to face when I was displaced and off country was no better for me. So I would much rather drive my 600k round trip and stay on country than be back in Townsville. No offense to Townsville, Professor Save, it's a beautiful part of the world. But, you know, when you're displaced, it has the social impact, especially with a young family and, you know, us as a family. My kids like running around under the sprinkler naked most of the year. So that's not really something you do in Townsville, you know, on a daily basis. So I've really been a grateful recipient of telehealth. I think for me, you know, as this journey comes to wind up in November, I'm on targeted therapy at the moment in Herceptin. It's a weekly dose. Unfortunately, because I've got a bit of cardiotoxicity, so we've just had to wind my dose down a little bit and spread it out. So I'm currently on 2 milligrams a kilo of that, funnily enough that I know that. But I would actually like moving forward to see, this is a photo of our local clinic, Camberwell. It's only 75k away from Avon. And, you know, I'd love to see this service offered in Camberwell, providing the training was there. You know, they've already got the telehealth system in place, so they just need the training. And you know, if I can help facilitate or, you know, be a voice to really advocate, you know, these sort of treatments getting out into these clinics, the benefits we'll see, as Professor Sabe touched on, to our Aboriginal and Indigenous population and our elder population. You know, it's just going to be huge. I don't know how you measure that, but I can tell you as an end user, hand on heart, that you know, it's been so important to stay at home and feel a little bit normal. So that's probably my experience with telehealth, and where we've come from and where we're at as a family. And yeah, can't speak enough about it, and so grateful to have been a participant with telehealth and part of this system.
Thanks, Maria, for a really interesting and such a stimulating insight into what the reality is for you. Being in such a remote location, I think it's very easy for researchers and clinicians who are living in big towns and cities to forget just some of the challenges that you have to face. But the fact that telehealth is offering you such a great opportunity to stay on country is really exciting. So thank you very much. We do have a couple of questions coming through already. Marie, I've got a couple for you. In terms of, do you have any suggestions for people around what innovations you see for the future of telehealth? I was really interested to hear your views on this the other day, and if you would be happy to share those with people, that'd be terrific.
Oh, sure, Nicole. So, I mean, I guess big picture for me, you know, it's my family down home in southern Queensland. We run a business where we have a lot of headers and harvesters, and we have a breakdown in the paddock, and you know, we can ring up our parts provider, and a drone can drop parts off in the paddock. Now, I mean, big picture for me, you know, why can't drones be flying around delivering medication to people in remote communities? I think that has got some wonderful, wonderful benefits as far as, you know, fighting another pandemic. Have we need to be there, and also keeping people on country. So, you know, I'd love to see drones whizzing past with a big package on with some life-saving medication. And, you know, the cost to gain that, and, you know, the money that can be saved there. I mean, you know, that's the whole finance department's team, but I can assure you it'd be a lot better for everyone.
Terrific, thank you. Marie, another question we had was around what advice would you give to new patients who are facing the prospect of using telehealth? Any words of, you know, advice on how to manage the process?
Yeah, look, that's a really good question. I think, like Michael mentioned on, I think it's really important to have the nurses and the people that are implementing it on the patient end well informed, so that you have got that person to turn to and ask any questions need be just regarding the technology. Certainly for myself, I'm quite a visual person. I've appreciated the screen being quite big. So I know when I'm ticking Dr. Joshi off enough that I need to back off a little bit so I can read those social cues. So everyone's really different with that. But I think if you've got the people on site that can answer any questions regarding potentially security, or, you know, for patients that are much older than myself going in there that mightn't quite be, you know, familiar with video calling and things like that. I think it's good to have those people on site to ease any concerns from there.
Terrific. Marie, one last question from the screen before we go to all panelists. One of our participants was quite curious about how you manage the need for hospital readmissions during chemo, and did you actually to move closer to the hospital for the weeks where you had that initial treatment, just in terms of getting the balance right for complications, and you know, if you have a febrile episode or something that's happening, how did you deal with that?
Yeah, look, that's a good question. I mean, we didn't really have a contingency plan, and that actually did happen to me. Ended up with 0 neutrophils and febrile one stage, and another 2 weeks in hospital with pneumonia. That's tricky when you're living remote and you've got a young family. We have got a support base in Mount Isa, so we're able to deal with those episodes as they happen. But I mean, how do you plan for that, really? I mean, that's just part of living remote. I mean, we get flown out. We've had 2 staff members flown out in the last month with different things with RFDS. Like, that's just part of living remotely. And, you know, it can be tricky, particularly when you don't have that support system in place in the towns. Like certainly when we went to Townsville, it became trickier for us. And like I said, there's no, it's no coincidence that once I didn't have that support around me was when we felt the real crunch, you know, and it's a grind. Radiation's a grind, so that was a real grind. And look, I don't know, apart from having advocates in hospitals that are dealing with people that are off country, I don't know whether that's maybe the answer, or having that network there. Potentially, I think that's really, it's very individual how people deal with that.
Thank you. So we'll open questions now to the whole panel. Don't forget to use the Q&A button at the bottom of the screen there for putting your questions through. If you want to direct a question to a particular speaker, just say, you know, this question is for. I think the most recent question that's come up now, probably I'd direct this to Sabe. This is around, is there a need to have an MOU or a memorandum of understanding with health services to utilise allied health? So Sabe, and then maybe Michael, you'd like to reflect on that one as well. Thank you.
I mean, if I look at the public or government sector perspective, I think it looks like if you go by the book, everyone wants an MOU or SLA, all sorts of things, and they waste 2-3 years on minutia. But we never waited for anyone for any MOUs. Is really because we are, as a Queensland Health employee, I just look at it as I working for Queensland Health. So then I just do what I think is good for the patients. But if you talk to the managers, they always drag you down into the MOUs. So I don't talk to them normally.
Thank you. Michael.
Yeah, good point. And same with us. As a private practice, essentially we don't need one. So anyone can refer into us, or patients can self-refer. So if we have an MOU or a service agreement, great. But otherwise, not necessary.
Okay, terrific. Another question from a little earlier, and any of the panelists might like to contribute to this, is around the collection of PROMs or patient-related outcome measures and PREMS data being collected at various time points throughout treatment for those people participating in telehealth. Is there any standard approach to how we ask people to report their outcomes and how that data is then getting used and perhaps better informing their care?
Yeah, so in terms of the PREMS, my observation has been, if you use telehealth, if you look at telehealth as another model of care like face-to-face, so whatever happens in face-to-face, it happens in telehealth. So if people are just taking the toxicity profile on the day of the appointments, then that's what they do in telehealth. But if they have an electronic system where they capture electronically, then they do that on telehealth too. So I don't think there's anything standard. So whatever people do in face-to-face is the one they're applying for telehealth.
Yeah, okay.
Yeah, and just to add to that, even the measures that we are collecting aren't standardized. We find that in every research context. Excuse me. So agreeing on it, maybe a baseline set of measures might have value. We use measures pre and post, and then collect symptom data throughout the week as well. But pre and post a program, we collect a whole range of outcome data. And after every video consult, we have a basic satisfaction and net promoter score that we can tie into a quality framework. So that works well for us, and it's 1 click or 2 clicks for a user.
Terrific. That's fantastic. Michael, another question that sort of relates a bit to what you've just picked up on is about sending documentation back to the referring clinician, whether that's the GP or the cancer clinic, or even, other allied health professionals that you're working with. How do you ensure that loop of communication is closed, essentially? So you've had the consultation and then you want to make sure that you're keeping people informed.
Yeah, absolutely. So, you know, if available, we use something like a secure message platform like Medical Objects. So that has value for us. But otherwise, you know, we're still using e-fax for some people, which is funny to talk about. But yeah, making sure that, you know, we're not just offering a siloed service as much as possible, that we're collaborating with primary care and specialists.
So Nicole, if I just want to add something, this is actually has been a bane in my life for a while. And I think this is where the telehealth, if you continue for even for metropolitan telehealth, the shared care model can actually be a fantastic opportunity here. So for rural, the first reviews are normally done with GP. So we dial into the GP practices as much as possible. So if we have some sort of mechanism where at least once a year, the specialist and the GPs and the patients are in one room, now I think, you know, we will achieve a great shared care system.
Terrific. Maria, I might just ask you from the patient's perspective, do you get any regular questions or opportunities to provide feedback about your experience telehealth and how that, you know, there's that need for you as a patient advocate really to say we need to support these sorts of initiatives?
Yeah, look, no, to be honest, and sadly, no. You know, I can give great feedback, and I've given fantastic feedback to the Mount Isa Hospital Board as far as my experience with the cancer care team in Mount Isa. But as far as actually driving the telehealth in itself, no, that's purely been conversations, but nothing formal, which is a shame.
Sounds like a great opportunity there for a bit more engagement in the future, to have people reaching out and talking to you about that.
Absolutely.
The next question is for Sabe. Sabe, what type of telehealth platform does Queensland Health use? And would you see that there's any advantages in all states and territories using the same system?
Yeah, I mean, it's always hard to, so in terms of Queensland Health, you know, we have the traditional big machines, hardware systems between hospitals, as Marie was saying. And then certainly, you know, I think all the states now have their own telehealth web portals. But then there's all this confusion about Zooms and Skypes and data privacy. So it's a bit of a dog breakfast. But I think it's all sorts of things. But I'm not really too fussed on what technology, as long as it's a seamless technology, then I think we should be able to use it. But certainly having, you know, one type of system throughout the country is always good. But even for COVID, we have 8 different shutdown measures. So good luck for that.
Very true. Okay. Well, we're heading towards being towards the end of our time. It is coming up to 12 o'clock. So if you would like to access a copy of today's presentation, it has been recorded. And so the team at Concert will make that available afterwards. The other thing that the team is going to do is post a webinar evaluation survey out via the email. So we'd be really grateful. We've had, I noticed at the peak today, 131 people on the session today. Even if we could get half of you to give us an evaluation, please tell us what you thought about the session. We'd love to hear, especially about how the formats work today with having our 3 presenters. Well, given that our time is up, I will say thank you very much to Sabe, Michael and Marie for some really interesting and thought-provoking insights into telehealth in this time of COVID. And we look forward to seeing some measures to really sustain these telehealth models that we've got in the future, and seeing how implementation science projects and communities of practice like this one can help to support those initiatives. So thank you everybody for participating today, and great to have your insights and wisdom. Thank you.